Good morning, everybody. My name is Alemayehu Duga. I'm a B.Pharm holder, Bachelor in Pharmacy, and doing my clinical pharmacy at Texila American University. My presentation will be on acute kidney injury, prevalence, diagnosis, and cause, as well as treatment plan for acute kidney injury. Um, Presentation outline. So I've got abstract, introduction, pathophysiology, classification of AKI, epidemiology, clinical presentation, evaluation, diagnosis of acute kidney injury. When I come to my summary, I will just define definition of acute kidney injury. It is an abrupt reduction in kidney function measured by a rapid decline in glomerular filtration rate, resulting in retention of metabolic wastes. Okay, so usually we have retention of metabolic wastes like fluids, electrolyte, and other waste products. So it's generally defined as a rise in serum creatinine concentration and blood urea nitrogen. Method of the study is it is a systematic review of different books and journals, and I came up with summary statement. So results using literature review or the definition, cause, and treatment algorithm was jotted down, which I'm going to present shortly. So when I come to pathophysiology of AKI, acute kidney injury, it's associated with prolonged hospitalization, substantial healthcare resource consumption, high mortality, and can lead to progressive kidney disease. So the cause of acute kidney disease can be related to renal anatomy. For example, vascular blood from renal arteries delivered to glomerular. Glomerular problem, ultrafiltration occur at glomerular forming ultrafiltrate, and renal tubules, reabsorption, secretion of solute water from ultrafiltrate occurs within the tubules, as well as urinary tract. Okay, so we can see pathophysiology of acute kidney disease in different ways. So classification of acute kidney injury, it can be classified into three different major causes: pre-renal, renal, and post-renal. Which I can put it in this way on this picture. So pre-renal acute kidney injury, it is due to renal hypoperfusion, that is low blood flow toward this renal artery. And the second one is intrinsic acute kidney injury, damage to kidney and tubules. And the third one is post-renal acute kidney injury, which is obstructive renal nephropathy. It can be prostatic hyperplasia or neoplasia. Okay, so these are the major three subclass of acute kidney injury causes. So classification in major causes. So pre-renal acute kidney failure can be due to hypovolemia, that is due to reduced blood flow, which is usually caused by hemorrhage, gastrointestinal fluid loss like vomiting, diarrhea, renal fluid loss due to diuretics, especially osmotic diuresis can be the major cause. Extravascular sequestration, burns, pancreatitis, and severe hypoalbuminemia. So these are the causes of pre-renal acute kidney failure. So most likely it is related to low blood volume or simply hypoperfusion. The second one is intrinsic. This is related to kidney problem, which is usually due to nephrons. So renovascular obstruction, diseases of glomerular and vasculature. So here intrinsic acute kidney failure will be about all about kidney problem and glomerular filtration as well as nephrons. The third one is acute tubular necrosis. So ischemia that is caused by the same for pre-renal acute renal failure, but generally the insult is more severe and prolonged. We've got infection with or without sepsis syndrome and toxins as well. Okay, so generally we can the three classifications will bring about acute kidney failure. When I come to the third one, it is post-renal acute renal failure. So it has to do with tubules that transport waste material from kidney towards urethra. So it includes urethra, bladder, neck, and ureteric tubules. We can classify acute kidney failure in different ways. The first one is called a refill classification, that is risk of renal dysfunction, injury to kidney failure, and the loss of kidney function. So based on this classification, we have around 4 different stages. The first one is risky stage. Glomerular filtration criteria and urine output criteria will be the 2 main important criteria to classify acute kidney failure under referral system. So the first one is risk. Serum creatinine will be increased by 1.5, or glomerular filtration rate will be increased greater than 25%. So during this situation, so it increases the risk of having kidney failure. The second one is injury. So serum creatinine will be increased more than 2 times, or it will be doubled. And the other one is failure. It will be increased by 3. And the final or the last one is persistent acute kidney failure. That is complete loss of kidney function. So this is usually when it's more than 4 weeks. So this is refill classification. We've got also another ways of classification, but usually we use refill classification to classify the disease or the pathophysiology of acute kidney failure. Epidemiology, there are very limited studies on acute kidney failure, especially in Africa. So this review will be a very good input to increase the study, especially in developing countries. Also, the overall precise incidence and prevalence of acute kidney injury has been difficult to ascertain. So a retrospective review from England estimated a yearly incidence of acute kidney injury in children as 0.8% in 100,000 population. So this is about 1/5 of total found in adults. In a retrospective view of a tertiary center in United States, 1/3 of hospitalized non-critically ill children developed AKI based on modified pediatric refill criteria. So what are the causes of acute kidney injury? So the most common causes of acute kidney injury includes ischemia, that is due to shortage of oxygen transportation towards kidney and its tubules. Nephrotoxic drugs, it will be the second most common common cause causing AKI. Sepsis, that is infection, and unknown. Okay, so the most common causes are ischemia, nephrotoxic, and sepsis or infection. By the way, this is like for developed countries, especially in America. So the common cause of acute kidney injury will be different for developing country, which I'm going to just display now. So for example, the best illustrated in a review of 7 studies, primarily from Asia, New Zealand, and Singapore, reports that incidence of primary renal disease is 43%, which is very opposite to that of developed countries. So In developing country, acute tubular necrosis will be 23%, hemolytic uremic syndrome 21%. So generally, when I can simply generalize the difference between developing country and developed country, the cause of acute kidney injury is a bit different. So these are the four phases of AKI. Onset phase, this is it lasts from hours to days. At this stage, it's possible to control AKI. The other one is anuric phase. Urine output will be less than 400 mils per day. The third one is diuretic phase, occurs when cause of AKI is corrected, which lasts from 7 to 14 days, and then the other one is recovery phase. So usually, if it's going beyond the recovery phase, most likely it will be irreversible. So how do you diagnose AKI? Serum creatinine concentration will be the major laboratory parameter which has to be looked at. Estimation of glomerular filtration gives an approximate number of functioning nephrons. So serum creatinine concentration is usually used clinically to estimate glomerular filtration rate. Otherwise, they are not directly proportional. So usually we have this parameter in newborn, infant, child, and adult. So if serum creatinine concentration is greater than 1 milligram per deciliter in newborn, so we can have an indication of AKI. Infant and child will be, you can easily see it from my presentation is displayed. So how do we treat AKI or acute kidney injury? So it should be correcting underlying cause of acute kidney injury. This is usually if it is in its earliest stage. Serum creatinine does not rise to abnormal level until large proportion of renal mass is damaged because of the indirect relationship of glomerular filtration and serum creatinine, because they are not linear. So the rise in serum creatinine may not be evident before 50% of glomerular filtration rate. So it cannot be observed that the current treatment of AKI is mainly supportive in nature. So no therapeutic modalities to date have been shown efficacy in treating this condition. So usually we just take care of the patient with AKI than giving therapeutic modalities. So otherwise, still we need to also be careful in administering certain drug which will exacerbate AKI, like dopamine, phenoldiazepam, and mannitol. Mannitol usually people use it for diuretics, which in this case will be a problem if we administer to AKI patients. Maintenance of volume homeostasis, correction of biochemical abnormality remain the primary goal of treatment, and may include the following measures: correcting fluid overload with furosemide, that is loop diuretics. So especially AKI patient will have edema around far extremities and in peritoneal cavity. So treating with furosemide will be a very good treatment option. Correction of severe acidosis with bicarbonate administration, usually because of the retention of acidic byproducts. So we need to correct severe acidosis with bicarbonate administration. Correction of hyperkalemia, usually due to low urine outputs, there will be hyperkalemia, which should be taken care of. Correction of hematologic abnormalities can be anemia. Usually, AKI patients or acute kidney failure patients will face a very huge anemia. So this should be taken care by administering drug which increases red blood cell count, or simply by transfusion. when I go to the second, my next slide, volume overload. Furosemide can be used to correct volume overload, which I've already mentioned. Hyperkalemia can be also treated by decreasing intake of potassium, diet, or tube feeds, exchanging potassium across the gut lumen, using potassium binding resins. It's also possible to start or initiate dialysis so that potassium will be excreted. When I come to the summary of my presentation, so acute kidney injury, or formerly called acute renal failure, is syndrome characterized by a rapid loss of kidney excretory function. So it's typically diagnosed with accumulation of product of nitrogen metabolism or decreased urine output. So it is clinical manifestation of several disorders that affect the kidney acutely. Acute kidney injury is common in hospital patients and very common in critically ill patients because it can be also caused by different drugs which are being administered in the hospital. So in these patients, it is often secondary to external events, how such events cause acute kidney injury is also controversial. So no specific therapy. There is no really specific therapy for acute kidney injury other than supportive therapy. So new diagnostic techniques, that is renal biomarkers, might help with early diagnosis. That is usually what you call it biopsy. Kidney biopsy will be very helpful in diagnosing AKI along with other laboratory parameters, which is glomerular filtration rate and serum creatinine level. So if patient survives the illness and do not pre-morbid chronic disease, they typically recover to dialysis independency. So the treatment option will be taking care of the patient up to dialysis to correct the electrolytes. So these are my references, and I'll end my presentation here. Thank you so much for listening. You're welcome for your questions.